and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and joining me today is one of my favorite people to follow on LinkedIn, the Christina Rodriguez. Thank you so much for being here today.
Thanks for having me.
So, Christina is a licensed social worker, and she also has a master's in business administration now. Congratulations on your recent graduation.
So much.
Goodness. So I think of you kind of as really a star in the healthcare world already, because I have really been seeing a lot of the silos of communication between the clinical side and the business side of healthcare, and it's really hard to find bridges, and you are definitely one of those bridges. Christina hosts a podcast called Outcomes, and she has dedicated so much time to demonstrating the ROI, or the return on investment, of addressing social determinants of health, and that is something I'm very passionate about and want to learn more about. So I'm hoping to learn more from you today. Thank you for joining me for that.
It's definitely my pleasure. Yeah. So I've been a social worker in the healthcare space for over a decade, and I started in hospice, home health, community health, SNFs, rehabs, then moved up to higher acuity of care. But the point is, I saw the same stories over and over throughout the continuum, throughout 3 different states, and people with real needs were showing up to a place that's kind of built to respond, but not to prevent. So I got really tired of the myths that we tell ourselves in healthcare about social work and social determinants of health in finance. And so on the front lines, we're told that it doesn't matter. In the leadership meetings, we're told that it's too expensive. But what I saw is that resources can't be both the reason why you don't do social care, but also the reason why you must. So we use cost as an excuse to ignore what actually saves money in the long run. And so I went to business school with a laser focus on finance, and to debunk that, wanted to speak the language of finance because that's what it takes to give social care the seat it deserves, not in the margins, but just in the core business strategy in healthcare.
That is so important, and I think it's really hard for the business of healthcare to think long term, because they're like, well, what if we go out of business? And we're not here long term in order to see those impacts, right? And so I think in your podcast, you were able to show some case studies where there was pretty quick turnaround and seeing the trickle down effects. One thing that I've heard a lot of places are using now to address social determinants of health is the rise of the community health worker. And I think it can be really confusing for people to think, well, what is that? And is that the same thing as a social worker? Like, what are the differences? From my perspective, it seems like they're able to offer some of the connection to resources without maybe the stigma that might be attached to social workers in some settings. Like, if they come to your door, then they're not necessarily known as the baby snatchers or adult protective services, right? But what do you think about that, and how would you differentiate like the levels of scope of practice that a community health worker can bring to addressing social determinants of health versus what a social worker can contribute?
I think it's sort of the difference between a an APP and a doctor, or just those other kinds of levels of skills. Social workers have a more honed in, more developed skills on addressing complex layers of social needs, as opposed to a community worker who probably would be better used. They can do a lot in terms of their scope and who they can help, but the surface, it's not as in depth as what a social worker is able to do. So I think that community health workers definitely fill an important gap, but we still obviously will always need social workers. Social workers will obviously have the ability to diagnose and provide therapy when you have that clinical specification, but they in general, all licensed social workers do have the ability to kind of navigate the complexities of mental health overlaid with really extreme poverty or lack of resources, with family dynamics, with policy issues, legal issues, and that kind of thing. So I'll just give you an example of actually when I first started. I started visiting and like doing home visits, and I met this patient and in this care home, and everybody told me that this care home was just top tier. I wouldn't need to go there. They don't need a social worker. It's, one of the best places. I was wasting my time, blah blah blah. Well, when I was visiting this patient, every time I went to see her, I noticed that she was always kind of turned on one side. It came to the point where I asked her turn to the other side, and if I could take a look, and she had all these wounds on her back. So it's kind of like you do need a higher level of skill when you have that layer, like those layers of complexity, low capacity with low social, like organic social support, that you'll probably need a higher level of skill, and you'll need to bring in an actual social worker because you need to know what you're looking for. I would also say, like, any time that there's issues of safety, environmental, whether it's environmental or like obviously personal safety, or if there's like any kind of active violence like domestic violence or gang violence or anything like that, then you want somebody like a social worker that has a more developed background.
Excellent. Thank you so much for explaining and providing some context there, because I think as we talk more about addressing social determinants of health, it's important to know who all the players are on the team and who you can call on for what. So, looking back at your clinical practice, Christina, I'd love to hear more about like where there was a human that you can't forget about who has really solidified this passion for you. Do you have any instances like that?
Obviously over the course of 10 years, I've collected many stories, but I'll share a recent one. Back when I worked in the ER, a patient that was one of our frequent flyers coming in very often. I was always kind of told that I was wasting my time, and you can't get through to patients like these. You just let them metabolize and kind of go back to the streets. And so it was just like this reoccurring theme for me. And again, it's not even like one specific patient. That's just like it was a common thing, especially just like where that ER was. And I was even told things like, if the streets are their home, well, then why can't they just discharge home? Well, the streets aren't anybody's home.
They don't have one to discharge to.
Yeah, and I get why that culture permeates, and I get why you get disheartened because there's no resources available, and so you kind of get into this thinking of like, I can't do anything to help this person anyway. So why even try? But it's also this thing is like we get so literal, and we get so attuned to seeing immediate results of our efforts. At my first interaction, it might look like, the patient just rejected, like didn't want help. That's, maybe throw a turkey sandwich at me, or like say,
You hope it's a turkey sandwich they're throwing at you.
oh, yeah, best case scenario. So maybe it's something like that, right? But then the next time they come, and it might be the next night or the next week, that maybe they let me give them a change of dry clothes and some extra waters for wherever they're going to go next. And then the next time, then maybe we can have a 5-minute conversation. And then the next time, it's a referral to a full-fledged referral to detox. And so it's these small things that kind of like yield a better return over time. So I was actually just on another, I just did another podcast about this, but where we were talking about how hospitals, just by their very nature, are these places that are rife with opportunity to intervene and make really fast course corrections, just the same way that you would have a crash car readily available all the time. If you have the right amount of resources, you can change the trajectory of, a lifestyle that's been lived a certain way for a long time. So whenever you have new life, death, or change of life, like a loss of mobility, loss of functioning, or some other consequence happening, that it forces a reckoning moment where a patient has to say to themselves, this life that I'm living, or this current trajectory, this doesn't match what my values are. This doesn't match how I perceive myself. So this is a moment where I need to make a change. And so it's such an important moment to be able to have something to help facilitate that trajectory, because what happens is that if they decide, I do want to make that change but nothing's available now, I'll go do it on my own time. Well, it's usually not as likely that they're going to follow up on that, because the fear sets in, and the doubt, and the who am I for wanting a better things kinds of sets in. And anyway, long story short is that that's how I really came to see, over just so many cases. If we kind of like zoom out and extrapolate across, again, that 10 years, it was just like, first of all, do we have the resources to help in the first place? And second of all, if not, what do we need to do to get them? But then also, is it the right kind of resources at the right time? Because I've also spent a lot of my time, and I don't mean like my time as in like, I mean like literal FTE that can be quantified, and like mileage and all these other things that healthcare agencies over the course of my career have poured into me in order to get these resources that inevitably were not the thing.
Mm.
So, an example, I've spent an afternoon driving to 3 different food pantries looking for adult nutrition, because they have a lot of things, they have a lot of products at these pantries, but they don't have the right thing. Or I've spent, hours sifting through boxes of clothing donations, and it's not weather appropriate, or the footwear is not appropriate for here in Phoenix, where it gets to 180-degree pavements. And, if we discharge patients without footwear, or, without the right kind of footwear, they can come back with some pretty severe burns. That's just the reality of the population that we serve, and the environment that we're in. And then another example is a transportation program that was supposed to be this like innovative, tech enabled, so it must be good kind of program, where it texts Uber information over to the patient before a discharge ride home. And again, that's important, because even though they're discharging and they're out of the hospital, even transportation home equals continuity. But what would happen is, like, if the patient's homeless, then obviously, like, they'll have a phone, but they won't have a way to charge it, or more likely they won't have service. Or it was that the 87-year-old patient wasn't able to shuffle to the car in time from the waiting room, and couldn't wait 4 hours waiting for a ride in the heat. Or it was in the case of a domestic violence patient, somebody fleeing domestic violence. Well, we know phone control is a really large part of that dynamic. And so the text message information would go to the abuser, either because they shared a phone, or they had control over the phone, or for whatever reason. But again, like that, obviously that does not become a safe discharge plan for that patient. Like, and we're putting patients actually in harm's way. So, again, just going back to our population, this service is now unusable for like half of our patients. And yet it's also the only solution that we have available. So that was kind of like, I guess, the scope of what I'm trying to do then and now, is honing in on the right kinds of solutions and how to make them operational in real life.
And I hear, as you're talking about that, a very familiar sound of moral injury and not being able to deliver what people need. Or sometimes when you see a way that you might could help them, but you don't have time. And if you were able to dedicate all of your attention to this one patient all day, you could probably get them into a better place. But how many patients would you have a day in a hospital? Like 40, right?
Like, personally, or like,
It's just like
I
our
agree.
social workers in the hospital have a lot on their list, and they do not have all day to dedicate to one person, even though one day might have made all the difference for that one person. Well, then what about the 39 other people?
Yeah, yeah. It's so that's the other thing, is like, we don't have an unlimited amount of resources, whether that's human resources or literal resources. And that's fine. No matter where you go, there's no such thing as unlimited resources, but are we strategizing and are we being really mindful about the resources? So, if I'm delivering food boxes to, a diabetic and they have day old donuts or day old cupcakes, like we have to ask ourselves what we're really doing here. On one hand, it's like, okay, well, that's still more than what they had before, or that's charity or whatever. That's also labor, that's also time, that's also distribution that probably could have just been better utilized in some other way. So, are we delivering day old donuts when we should be delivering like insulin or something that's just more effective?
So, is this something you've been able to address through your project and your school?
Yeah. So for the last year and a half, I've been working on my capstone, which is on how to quantify the impact of social care. So it's a framework. It stands for needs, expenditures, savings, break even, risk, and communication. So it's a step-by-step method that I developed to help social care programs prove their financial value in healthcare terms without needing full claims data or an actuarial team right away. So we could take like care coordination. If we're doing care coordination, for example, for us stroke patients, we can track prevented escalations just week by week. That's how someone could start. So every time a patient doesn't bounce back to the ER, we flag it. And, we phrase it like this intervention likely avoided a $1,200 ED visit or a 10K readmission. You can plug in your own, obviously, data, but stroke patients are high risk. Even the soft touches can yield huge savings. So that's MedRex, appointment follow-ups. Then you would quantify the time to treatment impact, creating a before and after snapshot. Like, for example, an average patient used to see rehab in 18 days. Now it's 7. And you can use that to estimate improved recovery odds, reduced length of stay, or less intensive downstream care. You can then coordinate touch points. So how many calls, reminders, med checks, referrals that you made per patient, and then match those to the outcomes like fewer missed appointments, adherence, and completed referrals. Like an example, we supported 27 patients in keeping neurology follow-ups this quarter, or at $250 per visit and a 30% no-show risk. Protected $2,000 in expected revenue and ensured continuity of care. And these small wins actually snowball to be quite a bit, especially if you're working within the average margins of a healthcare system in the United States. I think earlier this year it was projected to be about 4%. If we use that 4% margin, then it's like every dollar that you're saving the system is $4 that they don't have to make up in advertising and alternate service lines, in other ways through their system. So it's maximizing the efficiency of the hospital overall.
Well, I think you might have answered the $1 billion question before I even asked it. Oh, Christina, if I were to ask you a $1 billion question, where if you were given a grant for $1 billion, how would you like to see it used to strategically make the most sustainable impact?
It would build a national social determinants of health investment pipeline. I would probably not incorporate new pilots yet, but just for the programs that are already working and showing good outcomes, showing good returns, I would fund their data, their storytelling, their infrastructure, and connect them directly to those healthcare dollars. It's not that we have a lack of ideas. My podcast showcases multiple agencies and organizations that have done this really well. So it's more of a lack of visibility and validation and funding.
That is such a good point. I mean, that's exactly why I'm doing this podcast. For example, like you're doing yours, is to show the people who are already doing good work or have great ideas. Maybe they are working towards it like you are, or maybe they have a really good idea that they don't have the time or support to initiate, and they're like, please somebody steal my idea and go do this, and it would probably work out really well. So I love that you are sharing your framework and this idea for creating a pipeline to support social determinants of health, because you're right, there are so many people that are already doing this really good work, but visibility is a real issue, especially for people who are dedicated to giving all day, every day. They're not thinking about how to quote unquote promote themselves. So I really think that the work that you and I are doing to amplify other people who may not get that visibility otherwise. And I love how you said you would use the $1 billion to contribute to their storytelling, because just sharing those stories can really create ripple effects where people are like, oh, they did that there? Well, let's do that here. And they may never speak to each other. They may never meet. They may never know that that other person heard it and exists and is doing anything. And yet the work multiplies anyway. So that visibility you're talking about is really powerful.
Yeah. Well, thank you so much for saying that. I go back to the storytelling because I think that um one of the myths about healthcare finance, unless you learn it and you know it well, but it's that it all comes down to, you know, these logic models and what makes the most financial sense. But really, it's there's a lot more nuance to it. And so when you think about the logic models, it's not the logic models that create inform the decisions. The logic models explain and justify the decision. So you really need stories to illustrate how that logic plays out in real life. Because, you know, you and I could sit here all day and sort of understand how care coordination for a stroke patient would help to reduce ER hospitalizations, would help to encourage proactive patient engagement in their care, would contribute to overall health outcomes. But unless we have those stories to illustrate exactly how these things are playing out, that's not really something that the decision makers and higher levels would really understand, because they don't get that. So I'll tell you another example.
Hey, give me a story.
Yeah, we're all about stories here. I was talking about one of the programs that I worked with, and somebody from finance asked me, "How did you know that the value was owned by the hospital that was referring to this program and not?" You know, the family or some other, like the payer or some other entity themselves. And it really stopped me, because there when I was working with this organization, there was no doubt in my mind that the hospital was getting the full value. And that came from years and years of coordinating safe discharge of the discharge war rooms. It was
Good description of it.
as I was going through this program's data, their surveys, their even what they would tell me, like the narratives about how much coordination they got from the hospital, about how much equipment they needed to bring in, the trapeze lifts, about when they were getting the referrals, how soon after surgery they were getting these referrals, and also how much literal heavy lifting that their staff was doing. Um, that told me enough about the condition of these patients that I just instinctually knew these discharges would not have happened if it was not for this program. As you know, you and I know, because we worked in the front lines and we worked with patients, there is that gray area between when a patient is technically, in a perfect world, clinically optimized, but still doesn't have enough social supports in place to have that successful and seamless discharge. And so the clinical team will sort of, depending on where you work, but like in a perfect scenario, the clinical team will take that into consideration, hold off on a discharge. I think that on the higher levels, you know, in the C suite, we they kind of tend to think more in terms of the clinical team sets the discharge and determines medical optimization. That's true, but not all the time. And sometimes it's the social supports that are in place and the patient's safe home environment or lack of that actually informs the clinical decision. And so anyway, this program was one of those programs that made up for those gaps. It was doing a lot of really hard work, and it was being treated as a vendor and as infrastructure without any of the benefits of true partnership. So I'm glad I was able to work with them, but again, that takeaway is that that's something that I knew because I had that frontline experience. And so your frontline experience is strategy.
It's true. And I've heard other nurses describe their insights as, well, that's just common sense. And it's not. And it's not because people are dumb and common sense isn't common, as other people like to say. It's because your experience informs your perspective, and your experience provides you with expertise in an area that someone else is not going to have, because that's not in their wheelhouse of experience. They're not ever going to be able to read your mind or know what happened on a unit they've never set foot on. And so it is up to us to verbalize what goes on so that it can be addressed by the people making decisions who otherwise would actually have no idea what was going on. And it sounds super fundamental, because it is super fundamental. But you know what the number one hardest thing in the world is? Communication. Like, communication breakdowns, I think, are the bane of everyone's existence. So I thank you for making communication a priority and being a rising voice on LinkedIn, sharing your insights. When did you start really sharing your insights on LinkedIn? I just started following you a couple months ago, I think.
It was about a little over a year ago. It was horrible. Look.
What you were posting was horrible, or
Yes.
what?
Yeah, I wasn't because I wasn't posting any of this. I was posting like a lot of random things. I was just kind of like posting into the void. And so it wasn't until I got a little more goal directed and implemented a strategy that it went from just being a passion project into something that is actually getting a lot of momentum. I'm now the platform is still growing. I'm about 5,000 strong, and but still I have followers like internationally now, and it's because I decided to apply strategy. I didn't just go with vibes, or passion. I instead kind of really locked in on how to be useful, how to deliver immediately actionable insights, and how to use my perspective for the better good, I guess we could
For the
say.
greater good of all mankind. Well,
Yeah, and I think that's why I really preach going from, good intentions to strategy, because I've seen that how that unfolds in my own experience. So, when I have my health policy lab and a data team and 8 to 12 years of hard won insights, then it'll look a lot better, and it won't be so cringe. But I still believe that, if the version of you a year ago doesn't make you cringe, then that's cringe. That's embarrassing
because
because
you haven't grown enough to see a difference, right?
right. Yeah.
Yeah, well, I mean, I think your writing is incredible and very insightful. And I think everybody should follow you on LinkedIn, Christina Rodriguez. And I'll definitely put a link to that in the show notes. Did you have a website or anything you want people to follow you on as well?
LinkedIn's where it's all at right now.
LinkedIn is where it's at, and her Outcomes podcast.
And the Outcomes podcast, it's on Spotify and YouTube.
This has been the Nurse Rosa's Insights podcast. And if you enjoyed this episode, feel free to leave me a comment or send me a message. I'll have my info in the show notes as well. Please follow wherever you are listening, if it's on YouTube or if it's on Spotify or Apple Podcasts. And if you know someone else who is very insightful as a healthcare stakeholder and they have great ideas that you think they need to share, let me know. Introduce them to me so that I can amplify their message, because like Christina said, if we can share stories, then we can make some good ripples. So all right, and I will see you in the next episode.
Hey, thanks.